And the challenge I think that the government has, obviously, is the constituency, ARP being the largest body, and to have, anytime you get a capitated model of any sort, you're talking about a delivery network, probably narrower than free selection. And so that's the challenge it's always going to have. I think there's going to be little models of it. Just recently, we've been part of the provider-based payments for post-acute care. And so we've narrowed in the Phoenix market 63 providers down to about 15 that we work with. And so that's the kind of movement I think will happen. I don't think it'll go to a total capitated component, to be honest, just because of that free selection component. Jim.
I would tend to agree. I don't see much of the elimination of that in our market either. We have a couple predominant plans in Northern Southern California, but I don't see much change.
And the second one's really about bad debt. I think you brought up the fact that through the healthcare exchanges, essentially you expect like a buildup of bad debt. Essentially, if with a high deductible plan or even with any plan, if a patient buys into it and they stop paying for the plan, then you're not going to stop care. So do you expect, I guess, an increase of bad debt, based on things like that?
I would expect a substantial increase in bad debt from a couple areas. I mentioned about the health plans working directly in some cases with the employers. When this happens, the health system is not always aware of what's going on. And the best example I can give for this is what happened in California with CalPERS, the California Retirement System, where they aligned with Blue Cross and they did a cut at $30,000 for an orthopedic procedure. They went to MedPAR and OSHPA data, and cost report data, I should say. And when they made that slice, they